we had a dinner. But first, we have the second best practice example of personalized medicine policy, which is Miguel Antunes from National Authority of Medicines and Health Products, who's going to talk about personalized approaches of the Portuguese adverse drug reaction. And please, when Miguel is done, don't rush out, because I have some additional announcements. Thank you.
Good afternoon, everyone. Guten Tag. Thank you very much at the organization for inviting us to be here presenting this best practice. I've just realized that I'm the only thing standing between you and dinner, so I'll promise I'll make it very swift. This is a different presentation because I've listened to all your presentations, and they are very interesting and focused mostly on genetics and genomics. Our system has also a component of a genomic project, but it is also focused on other personalized approaches. Some are stratified approaches, others are IT personalized approaches, so bear with me. So I work in the pharmacovigilance department, and pharmacovigilance is concerned about adverse drug reactions, especially the most serious ones and the unexpected ones. Of course, as you all know, before a medicine is placed on the market, it undergoes clinical trials, but those clinical trials exclude populations that are probably even more susceptible to adverse drug reaction, as are children, the elderly, and pregnant women. So it is only when the drug is finally put on the market that we have a full profile of the drug safety. And I'm quoting EMA, the European Medicines Agency, it is therefore essential that the safety of all medicines is monitored through their use in healthcare practice. It's quite interesting and convenient that I'm doing this presentation today, because we are just undergoing the third awareness week for adverse drug reactions. It's a campaign that is set up with a number of organizations, which includes the WHO and EMA and other organizations. And it's especially focused on creating awareness on the importance of adverse drug reactions. This year, it is mostly focused on special population, children and pregnant women. So I'm not sure if you've already seen some of these small videos. If I can get a little help. Technology isn't helping. Thank you. Okay, these are very short and brief animated figures, just to create, as the name indicates, awareness on the problem. Most pharmacovigilance systems are supported on a spontaneous reporting system, which means that a network of professionals and users report adverse drug reactions to a centralized system that then goes further up the scale. In Europe, we communicate all those adverse drug reactions to the EMEA, and then they communicate it to WHO, which has a global network and database for drug reactions. Of course, this is all interconnected, and we work nationally all together, and we have work sharing on certain substances. So what are the major challenges for pharmacovigilance today? I've decided to quote the head of the pharmacovigilance department, because she's very recently done a publication on what she considers are the greatest challenges in the area. And she grouped those challenges in two areas, which she called technology and people. And I think that probably those are the two main areas for challenges in pharmacovigilance. In technology, we have the questions related to handling big data, real-world evidence, the clinical registries and electronic health records. How do we gather information that is within those registries and records? And also from social media, and how do we get all this information to become something that we can really act upon? And also people, because we can't have technology without people and vice versa. So we now need greater involvement from healthcare professionals, and we need greater involvement from patients and users. So what is the strategy? So we like to call it a more personalized approach, which is more of a stratified approach. So we are now targeting healthcare professionals, but in a more stratified way. So how can we communicate better with those healthcare professionals? How can we stimulate them to participate more in our system? How can we get them to bring their expertise on the system? How can we get them more involved in doing research in pharmacovigilance? How do we get them more involved in the decisions of the benefit-risk analysis? But also we are focused on getting the users more involved in the system. How do we help them to communicate? How can we communicate better with them? How do we get more feedback from the users? And how do we get them also more involved in the final decisions on what regards benefit-risk analysis? So in Portugal, we've decided to make it more personal, which means that we've decided to make a very regionalized system. And we are working probably on getting it even more decentralized and regionalized, so that we can really get to the regions and to the communities, so that we can get all the people more involved, the professionals and the patients. Also, we've used technology to better end, and we've decided to get rid of the reporting based mostly on paper and forms, and now we are using a new technology, a new ADR system which we call Portal RAM. And it's quite friendly to use, and you can even report an adverse drug reaction using your cell phone, which most of the professionals and the users feel it's most convenient. So we've adjusted to the way communication is going today. And we'll probably do something like that in the future. So we've used that also to tailor our communication when we communicate with the professionals. And currently we are doing an inquiry mostly on healthcare professionals, but mostly on physicians and pharmacists, to know how they want us to communicate with them. How do they want to get information from the agency regarding the safety of medicines? Because other countries have done those inquiries, and they've come up with some very interesting answers. Some professionals do prefer to get their information in writing, for instance, which was quite surprising for us, but probably we can have a very tailored approaches to different professionals. Not one system fits all. Also, we are trying to get some innovation on the process. We consider that algorithms can really help us do a more personalized approach and strategy when dealing with adverse drug reactions. For instance, we are studying the use of an algorithm to identify patients which probably are more at risk of suffering an adverse reaction, so we can target them before they suffer that side effect. We are also trying other algorithms or softwares to help us develop more quickly our process and to get the professionals more involved in the process, so that the bureaucratic charge of the process won't be so burdensome as it is, for instance, we require MEDRA coding, which is a special coding for the cases of pharmacovigilance. And probably if you can get a software to get us some help with that, it will be most welcomed. We are also trying to create on the professionals the need to have a good clinical history when they prescribe a medicine. So we've now rechanged all of our information to healthcare professionals so that we can clearly focus on what is the probable individuals that will suffer mostly a certain adverse drug reaction. An example is a very recent one, which is metamizole, which has been a very high-profile medicine on the news lately. But when we've done the information on the potential risks of agranulocytosis and metamizole, we focused especially and mostly on which patients would suffer probably an adverse drug reaction to metamizole. So which patients should be under the scrutiny of the physicians when they prescribe metamizole. Also, we've looked at PREPARE, and we thought of how we could get a system and how we could get a project of pharmacogenomics to help us with the prevention of adverse drug reactions. And we've studied the protocol, but we've designed on something a little bit different, because PREPARE has also a very large component, as you know, of assessing the implementation of the process. And we are still, I believe, in Portugal, in an earlier phase, because we still are trying to get more information on how a drug reaction occurs, which are the mechanisms involved. So we, on the project, believe that there is some research phase that still has to be undergone. So we've designed our pilot project a little bit different, and it's mostly focused on the occurrence of an adverse drug reaction from a patient. We've focused mostly on adults, mostly because it's an easier population to study and to get them involved in a genetic study. If that patient experiences an adverse drug reaction, he is seen by a clinical doctor, which is an assessor of that adverse drug reaction. That information is then sent to our department, the Pharmacovigilance department, which, based on certain criteria, as is the seriousness of the reaction, the existence or not of a multiple history of adverse drug reactions previously experienced from that person, and also what we call the clinical interests of pharmacogenetic testing, which is a more vague criteria, but probably it has to do on the combination of having a certain reaction with a certain medicine. Probably could be interesting to undergo a pharmacogenetic testing. If those conditions are met, then we go back to the first medical doctor, the reporter of the adverse drug reaction, and we tell them that probably there is a patient that we would recommend to undergo a pharmacogenetic study. He then goes back to the patient and he asks for consent. He explains the interest of the process and he asks for its consent. If it's given, he sends him to a pharmacogenetics consultation, a clinical consultation, which has a very standardized protocol. And at the end of the consultation, a sample is collected. The sample is then processed with a pharmacogenetics panel, and then that information is set in a database. That information is globally stored and it's analyzed. And we are also trying to keep a focus on the cost benefit of the whole project, as this is a pilot project. So we want to gather all information, including the economical one. And then we have some recommendations for future actions. So my take-home messages would be, these are very new and exciting times of massive technology and science outbreaks, so we need to have very clever strategies to keep us very effective and efficient on how we get in touch with each professional or patient. Of course, we welcome new science and technology, and we need them to get a more personalized pharmacovigilance system. Still, not all personalized medicine is about something new. Sometimes it's about getting something tailored, like an old suit, to make it fit more conveniently. Thank you very much for your attention.